valvular heart disease. In that, mitral stenosis, mitral regurgitation, and aortic regurgitation are three topics which are asked as 5-mark question once or twice or thrice. But this AS, that is aortic stenosis, has been asked only as 3-mark question. So I request you to go through it after the class. Let's continue with the interesting topic, that is valvular heart disease. The valvular heart disease, the term itself suggests that the valves of the heart is involved. If the mitral valve is involved, which is between left atrium and left ventricle, it can manifest itself as mitral regurgitation and mitral stenosis. First, we are discussing mitral stenosis. As always, let's discuss the etiopathophysiology of mitral stenosis. The mitral stenosis, the term itself tells that the mitral valve is stenosed, meaning the surface area of mitral valve is reduced. We have progressive MS, severe MS, and very severe MS based on the area of mitral valve, which we'll come to it shortly. Now, why the mitral valve gets stenosed or get narrowed? The stenosis most commonly overall is due to rheumatic heart disease. After an attack of acute rheumatic fever, 15 to 20% of patients in the span of 2 decades, that is 20 years, develops mitral stenosis due to damage of mitral valve. We know the characteristic fish mouth appearance of the mitral valve in case of mitral stenosis due to rheumatic heart disease. There will be commissural fusion in case of mitral stenosis. What is this commissural fusion? The commissures are nothing but the area where the anterior mitral leaflet meets the posterior mitral leaflet. When the joining area of these two anterior and posterior leaflet, mitral leaflet, get fused, it leads to mitral stenosis. There may be associated calcification with the commissural fusion in case of mitral stenosis. Now, what is happening in heart due to mitral stenosis? When there is reduced area at the atrioventricular valve at the left side, there is reduced opening, leads on to impaired emptying of left ventricle blood into the left atrial blood into the left ventricle. Before studying all about cardiac effects, let's briefly review the physiology of cardiac cycle. We all know the end of diastole starts with atrial systole, which is responsible for push of blood from atria to ventricle. After atria systole, we have isovolumetric contraction. During isovolumetric contraction, both the AV valve, that is atrioventricular valve, and the aortic valve and pulmonary valve will be closed. The heart will be contracting in a closed chamber, so it's called as isovolumetric contraction. After this, there will be opening of aortic valve leading on to efflux of blood. We have two types of emptying, that is rapid isovolumetric. After the ejection of blood from the left ventricle, that is called as ventricular ejection. After that, after ejection, we have isovolumetric relaxation. So we saw that first there will be atrial systole, emptying the blood from atria into ventricle. Following that, there will be isovolumetric contraction, where there is contraction of left ventricle and right ventricle against closed valves. After that, there will be ventricular ejection into the aorta and systemic perfusion. After ventricular ejection, we all know that there will be closure of aortic valve and pulmonary valve leading on to S2, that is second heart sound. After that, there will be isovolumetric relaxation. After isovolumetric relaxation, at this point, our mitral valve should open. Mitral valve should open. so that the ventricles get filled correctly. So the mitral valve in this case will be stenosed and the filling will be defective. We see the secondary effects afterwards. The filling is divided into rapid filling and after that rapid filling we have of atria. After that we have atrial systole. So this is about cardiac cycle where we have atrial systole, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, followed by ventricular filling, that is rapid filling and delayed filling. Following that we have atrial systole. This is the physiology. What happens in pathology? So due to reduced opening of mitral valve following isovolumetric relaxation, there will be increased left atrial pressure. Please note the left atrial pressure has increased now because it's not opening correctly. Here the blood will pour and the left atrial pressure will increase. This increased left atrial pressure will transmit the pressure into the pulmonary capillaries, causing the increase in pulmonary capillary wedge pressure and the secondary effects which we'll see shortly. I briefly touched upon etiopathophysiology of mitral stenosis. Why stenosis? Most commonly due to rheumatic heart disease. What are the other less common causes of mitral stenosis? Those are congenital mitral stenosis, systemic lupus erythematosus, rheumatoid arthritis, gout, etc., etc. We have so many causes. If you remember 3 to 4 causes, we can answer in the exams. This is about the etiopathophysiology. Let's see the types of mitral stenosis. Based on the surface area of mitral valve, we have progressive MS, severe MS, and very severe MS. What is progressive MS? Progressive mitral stenosis is a type of mitral stenosis where the mitral valve area of the patient is more than 1.5 centimeter square. If the area of mitral valve is less than 1.5 centimeter square, it is called as severe MS. If the mitral valve area is less than 1 centimeter square, it is called as very severe MS, mitral stenosis. What are the clinical manifestations of progressive MS? Progressive MS on exertion, like exercise, stress, or during fever or pregnancy. Due to fever, stress, exercise, and pregnancy, there will be tachycardia, meaning increased heart rate. What happens when heart rate increases, guys? When heart rate increases, the heart rate is increasing by reducing diastolic time. When the diastolic time is reduced, there will be reduced filling of left ventricle. So here in MS, already the filling is reduced due to tachycardia. It is still worsening. Due to that, there will be increase in left atrial pressure and pulmonary capillary wedge pressure, leading on to dyspnea on exertion. So the clinical manifestation of progressive MS is dyspnea on exertion. How to manage the patients with progressive MS? We manage them by giving beta blockers, which reduces heart rate of the patient, thereby helping it to fight dyspnea on exertion. We all know that the increase in heart rate is the cause for progressive MS, so we reduce the heart rate by giving beta blocker. The patient goes happily to home. What happens in case of severe MS? In severe mitral stenosis, the mitral valve area is less than 1.5 centimeters square. The disease is progressing, guys. From progressive to very severe, the disease is progressing. Some patients are asymptomatic and some are symptomatic. What is the pathophysiology and manifestation that we see in severe MS? We saw, guys, due to mitral stenosis, there will be increased left atrial pressure due to back pressure. Due to increased left atrial pressure, the pressure is transmitted to pulmonary veins. from pulmonary veins then to pulmonary capillaries, causing increase in pulmonary capillary wedge pressure. Then the pressures are now the patient has, due to increased left atrial pressure, now the patient has back pressure causing pulmonary venous hypertension and increased pulmonary capillary wedge pressure. Due to increased pulmonary capillary wedge pressure, the patient will have characteristically PND, paroxysmal nocturnal dyspnea. Okay. After this, the disease progresses. Disease progresses. In next 10 to 15 years, the venous and capillary, which are experiencing large pressure due to back pressure, increased left atrial pressure, will undergo arterialization. This leads on to partial improvement in the symptoms of patients. When there is arterialization of pulmonary veins and capillaries, it leads to improvement of symptoms because these are more resistant compared to the previous vessels, unmodified vessels. There is partial improvement in the patient symptoms. He feels happy, and 5 years after that, he develops pulmonary hypertension. Pulmonary capillary wedge pressure increase leading on to pulmonary hypertension. Due to pulmonary hypertension, we all know that it puts more pressure on right ventricle, So the right ventricle can't sustain that much pressure, leading on to right ventricular failure. And then the right ventricular pressure are then transmitted on to tricuspid valve, leading on to tricuspid regurgitation. We saw, guys, there is increased in left atrial pressure, leading on to increase in pulmonary capillary wedge pressure. Within the span of 10 to 15 years, will lead on to pulmonary hypertension, which eventually lead on to cor pulmonale, right ventricular failure, and tricuspid regurgitation. This is the pathophysiology, what goes on in severe MS. What are the clinical manifestations due to this? The clinical manifestation due to this pathophysiological changes are due to increased left atrial pressure. There will be stretching of left atria leading on to atrial fibrillation. The patient may have dysphagia due to the enlarged left atrium compressing upon the esophagus, which runs on the posterior part of left atrium. There may be Altner's syndrome, meaning when the left atrium is enlarged, it may compress upon the left recurrent laryngeal nerve, which is hooking through the aorta, causing hoarseness of voice. That is called Altner's syndrome. And then we all know, guys, when there is stasis of blood inside the left atria, mitral stenosis, there is reduced emptying, stasis of blood inside the left atria, leading on to clot formation and thromboembolism. These are all the clinical manifestations due to increased left atrial pressure. Due to increased pulmonary capillary wedge pressure, we saw there is paroxysmal nocturnal dyspnea. And also, after the patients develop pulmonary hypertension, patient can have features of right ventricular failure. Those are features of congestive heart failure, that is hepatic enlargement, the spleen congestion, peripheral edema, ascites, etc., etc. We all know the features of congestive heart failure. We have discussed this previously. So these are all the symptoms that we see in case of severe MS. Those are related to increased left atrial pressure, increased pulmonary capillary wedge pressure, and related to pulmonary hypertension, that is dyspnea, and also right ventricular failure related symptoms where we see congestive heart failure symptoms. Then we have very severe MS where the mitral valve area is less than 1 centimeter square. This stage, the patient will have left ventricular failure and the features of left ventricular failure. So under clinical manifestations, you can write from here to here. All the manifestations you can write. What are the examination findings that we see in case of mitral stenosis? On general physical examination, we can see mitral facies, where the patient has malar rash, cyanosis at the tip of nose and lips. This is called mitral facies. When we see the pulse of the patients, there may be irregular pulse due to atrial fibrillation. We all know this point. When we see JVP, there may be prominent A wave due to the enlarged atria and the contraction of atria against the stenosed mitral valve leads on to prominent A wave. These are the general physical examination findings. What are the CVS examination findings? When you examine the precordium, you can get palpable P2, that is palpable second heart sound due to pulmonary hypertension. There is back pressure, guys, into the right ventricle. Due to that, the ventricle is exerting much more pressure to contract against the pressure, leading on to the palpable second heart sound due to the back pressure at the level of pulmonary valve. Then we have left parasternal heave due to the right ventricular enlargement, which is seen in case of severe MS, where we see right heart failure. Left parasternal heave. This is on examination of precordium. What are the heart sounds and murmur that we see on auscultation? There will be characteristically loud S1 because the mitral valve stenosis is closing the zone of coaptation. When it closes quickly, top, it leads to loud S1. And also there may be characteristically wide splitting of S2. When we go to murmur, what are the murmur that we see in MS? Mitral stenosis. We know, guys, mitral stenosis is affecting which phase of cardiac cycle? It's not systole. Why? During systole, the mitral valve is closed. It is the mitral valve in mitral stenosis closes appropriately. So we don't see systolic murmur in case of mitral stenosis. Rather, we see diastolic murmur because there is diastolic dysfunction in case of mitral stenosis. The duration of murmur is directly proportional to the severity of disease. Following closure of aortic valve, imagine, guys, imagine following closure of aortic valve, there is isovolumetric contraction of the ventricle, isovolumetric contraction. Then it should be followed by, sorry, I told ulta. Following the S2, that is closure of aortic valve, there is isovolumetric relaxation, relaxing, ventricle is relaxing. Now the mitral valve should open adequately in order for adequate filling of left ventricle. In this case, it's not happening. The mitral valve is diseased. While opening, it produces an opening snap. After opening, the blood passes through the stenosed mitral valve, leading on to turbulence at the mitral valve, which gives mid diastolic murmur. And then at last, at the end of diastole, we know that there is atrial systole. This atrial systole causes pre-systolic attenuation of sound. So we saw, guys, in case of mitral stenosis, we see mid-diastolic murmur with pre-systolic attenuation of sound, which is due to atrial contraction. These are all the examination findings that we see in MS, that is mitral stenosis. So we are done with etiopathophysiciology, clinical manifestation and examination findings in case of MS, that is mitral stenosis. How to get the patient? Very simple, guys. Do chest X-ray. There you will see enlarged left atrial appendage due to increased left atrial pressure, and then secondly there will be increased enlargement of left atrial appendage. And also, when you do transesophageal echo, you may see the thrombus. If you see, treated adequately with anticoagulants, warfarin. And also characteristically, by doing Doppler study, we can diagnose MS, mitral stenosis. What is the management of this condition, guys? Mitral stenosis. So if the patient has clots or has atrial fibrillation, we should give warfarin to the patient because it may lead on to thromboembolism afterwards. The definitive management of mitral stenosis is percutaneous mitral balloon valvotomy, meaning pass a balloon into the chamber, inflate it, and make the stenosed mitral valve widened. We can't do this procedure if the patient has calcific mitral stenosis or he has developed thrombus. In those cases, we'll do open heart surgery and do mitral valve replacement. This is about the management of this condition, mitral stenosis. Let me summarize mitral stenosis for you once again. Etiopathophysiology, we saw most common causes rheumatic heart disease. The other less important causes like rheumatoid arthritis, SLE, that is systemic lupus erythematosus, or congenital mitral stenosis we have, which leads on to commissural fusion. There will be increased left atrial pressure and increased pulmonary capillary wedge pressure. We saw the cardiac cycle briefly. Then we saw types of MS, mitral stenosis, that is progressive MS, severe MS, and very severe MS based on the area of mitral valve. The progressive MS characteristically present with dyspnea on exertion, which is treated with beta blockers. The severe MS, the patient will present with paroxysmal nocturnal dyspnea, and then features of pulmonary hypertension, the dyspnea, and then these features of cor pulmonale, the congestive heart failure features, like peripheral edema, ascites, and features of tricuspid regurgitation. And then we saw clinical manifestation findings. The mitral facies, irregular pulse, prominent A wave on JVP. We saw on precordial examination, we see palpable P2, palpable second heart sound, and left palatal heave. Diastolic murmur, we see mid-diastolic murmur with pre-systolic attenuation of sound. We see loud S1 with wide splitting of second heart sound in case of MS. Following that, we saw in very severe MS, there will be left heart failure and the features of it. The investigation, chest X-ray, echo, transesophageal echo, and Doppler study. And the management, we saw if the patient has clots or atrial fibrillation, we give warfarin. And the definitive treatment, we give percutaneous mitral balloon valvotomy. If the patient has calcific MS or thrombus, we can't do this procedure. So we'll proceed on with mitral valve replacement. We are done with mitral stenosis now. Mitral regurgitation is of two types: acute mitral regurgitation and chronic mitral regurgitation. Chronic mitral regurgitation is more important for us. I will mention about acute mitral regurgitation briefly. What are the causes of acute mitral regurgitation? There can be rupture of chorda tendineae, which holds the valve. The rupture of chorda tendineae, seen in case of infected endocarditis, can lead on to acute MR. The papillary muscles, which are attached to chorda tendineae and valve, may rupture, giving due to inferior wall MI or due to infections. These are the causes of acute mitral regurgitation. When there is acute mitral regurgitation, what is happening, guys, in case of acute mitral regurgitation? Mitral regurgitation means normally during systole, the blood should go in one direction, that is to systemic circulation, aorta. In case of chorda tendineae rupture or papillary muscle rupture, in acute mitral regurgitation, during systole, there is regurgitation of blood into the left atrium. This leads on to increased left atrial pressure, leading on to back pressure and pulmonary edema. That same story which we are doing from since 2 days. Then we have the more important one, the chronic mitral regurgitation. What is the etiopathophysiology of chronic mitral regurgitation? In chronic mitral regurgitation, we have two kinds of chronic mitral regurgitation. Those are primary MR, primary mitral regurgitation, and secondary MR, that is secondary mitral regurgitation. What is primary mitral regurgitation? Primary mitral regurgitation is the mitral regurgitation due to primary pathology involving the mitral valve. The secondary mitral regurgitation or the functional mitral regurgitation is the mitral regurgitation due to secondary causes like HCM, that is hypertrophic cardiomyopathy, or left ventricular dysfunction leading on to annular dilation. What are the causes of primary MR? We have rheumatic heart disease. It can be chronic rheumatic heart disease or acute rheumatic heart disease with carditis causing on to MR. We have mitral valve prolapse as one of the primary cause of mitral regurgitation. The mitral valve prolapse is one of the most common cause of mitral regurgitation in developed countries. And also we have autoimmune attack to the mitral valve, damaging it and causing regurgitation in case of SLE, that is systemic lupus erythematosus, and RA, rheumatoid arthritis. Before that, guys, sorry, I had to mention the anatomy before itself. I'll mention it for you now. In the in the valve, we have leaflets, that is anterior and posterior leaflets. The joining area of those two leaflets is called as commissure. The periphery of the leaflets has fibrous thickening called as annulus. The valve are attached to papillary muscles through chordae tendineae. These are fibrotic bands. And then we have papillary muscles, which are projections from the myocardium of ventricles. We saw the causes of primary MR and secondary MR. Primary MR can be due to rheumatic heart disease, mitral valve prolapse, or due to autoimmune attack to the valve. And the secondary or functional causes of MR, this is mitral regurgitation. We have hypertrophic cardiomyopathy due to pressure section. The pressure section, the negative pressure due to Venturi effect causing suction of mitral valve and leading on to secondary MR in case of HCM, that is hypertrophic cardiomyopathy. In case of left ventricular dysfunction, due to annular dilation, this annulus get dilated, leading on to MR, that is mitral regurgitation. What is the pathology in case of it? Pathophysiology in case of mitral regurgitation. The story of mitral regurgitation, let's see. I told that during systole, blood should only go through aorta. But here, during systole, the blood will go back into the left atrium. And after it goes back into the left atrium, during ventricular diastole, the blood which has gone into the left atrium will come back into the left ventricle. So there is increased amount of blood coming on to the left ventricle in each cycle. Due to that, the left ventricle will undergo eccentric hypertrophy. The left ventricle will undergo eccentric hypertrophy, meaning the left ventricle get dilated and hypertrophy, which may eventually lead on to left ventricular failure due to systolic dysfunction. The alt muscle dilate. It reaches into the phase that when it can't contract adequately, leading on to left ventricular failure. Of MR, mitral regurgitation, there is regurgitation during systole, leading on to the increased blood coming into the left ventricle, following the blood going into left atrium and coming back to left ventricle, leading on to eccentric hypertrophy of the left ventricle, which will eventually lead on to left ventricular failure. After left ventricular failure, we can have increased left atrial pressure. So this is about the pathophysiology in case of MR. What are the clinical manifestations seen in mitral regurgitation? We have two types of mitral regurgitation, that is mild to moderate mitral regurgitation and severe mitral regurgitation. How to classify the patient as having mild to moderate mitral regurgitation and severe mitral regurgitation? Mild to moderate mitral regurgitations are the patients who are asymptomatic. are the patients who only have palpitations, whereas the severe mitral regurgitations are the patients who have left ventricular failure, the last stage. We know the features of left ventricular failure. Due to reduced perfusion, there will be lightheadedness, there can be syncope, there can be fatigue. Now, due to back pressure, due to left atrial pressure increase, the patient may have dyspnea and orthopnea. And also other features of left ventricular failure we can see here. So what are the clinical manifestations? What are the examination findings that we see in mitral regurgitation? In general physical examination, while we check the pulse of the patient, we have pseudo collapsing pulse. Let me break down what is pseudo collapsing pulse for you. I told that during contraction, systole, there is increased blood going into left atrium. After that, all the blood will come back to left ventricle. So there is increased filling. Increased filling will lead on to increased ejection. Frank Starling's law. So there is increased force of contraction of left ventricle. So there is rapid surge of pressure. Saying that the blood starts leaking at the mitral valve, which leads to sustained pressure. Following that, there will be the aortic valve closes and the process of diastole starts. So the pressure decreases again. So this is called a pseudo collapsing pulse. This is pseudo collapsing pulse. Collapsing pulse we'll see in AR, where there is rapid upstroke followed by rapid downstroke of pressure. We'll see why when we discuss AR. Here there is rapid upstroke followed by sustained pressure and then rapid downstroke. I hope all of you understood the mechanism behind pseudo collapsing pulse. Then due to left heart failure, the patient may have narrow pulse pressure, which is quite intuitive. And also on JVP, due to the increased contraction of left atrium, we may have V wave prominence on JVP. What are the CVS findings? We know the left ventricle is eccentrically hypertrophied. Due to that, the apex, left ventricular apex, will move downwards and outwards. And the eccentrically hypertrophied left ventricle will be hypokinetic. So, on palpation of precardium, we see down and out and hyperkinetic apex of heart. Auscultation, we will see soft S1. We all know that when there is contraction ventricular systole, the anterior and posterior leaflet of mitral valve will close. The zone of coaptation will be formed. Due to this, there will be S1 sound heard. Here in MS, the zone of coaptation, the meeting of those two, is not so adequate, leading on to soft S1. The S2 may be normal or it may have early A2 due to backflow of blood into the left atrium during systole. There is no more compared to normal. There is less blood going through aortic valve, leading on to early A2, early closure of aortic valve, which gives a wide splitting second heart sound. We can see S3 due to increased blood pressure, increased blood reaching the left ventricle. Why we see S3? The third heart sound we see because whenever the blood comes down into the ventricle, left ventricle, with force, it comes out and makes the third sound, which is gives sound to S3. We all know that there is increased amount of blood coming on from left atrium to left ventricle in mitral regurgitation due to backflow of blood during systole. So we will see S3. Even without failure, we can see S3 in case of mitral regurgitation. What are the cardiac sounds that we see? The S1 will be soft, S2 will be wide split with early A2, S3 we can hear in case of mitral regurgitation. Now, what is the murmur that we see in case of mitral regurgitation? Mitral regurgitation is occurring during systole. The regurgitation of blood is occurring during systole, leading on to turbulence at the level of mitral valve during systole, giving rise to pansystolic murmur, which radiates to axilla and back. This is about the clinical manifestation and the clinical examination findings and clinical manifestation in mitral regurgitation. What are the investigations? As usual, we can do echo, where we can see the mitral valves which are not closing correctly during cardiac cycle. We can do ECG, or else we can do transesophageal echo. All those investigations we can do. And also we can do X-ray. On chest X-ray, we can see the enlarged left ventricle. These are all the investigations that we do in case of MR. Now, how to manage these patients? We have asymptomatic patients and symptomatic patients. We saw the asymptomatic patients are treated only when they have ejection fraction less than 60% and left ventricular end systolic pressure more than 40 mmHg. Not telling left atrial, it is left ventricular end systolic pressure more than 40 mmHg. If the patient is asymptomatic when ejection fraction is less than 60 and left ventricular end systolic pressure is more than 40, and if the patient is symptomatic, we will do mitral valve repair, or we can also replace the mitral valve. That is called as mitral valve replacement surgery. So we saw all about mitral regurgitation, acute mitral regurgitation occurring due to chordotenary rupture, papillary muscle rupture, leading on to increase in LAP, that is left atrial pressure, acute increase in left atrial pressure, leading on to pulmonary edema. Okay, now I got why Kaushik is asking a doubt. There is acute. Here I am telling increased left atrial pressure. Here I am telling no, the left atrial pressure is not increasing initially. Why so? Because here there is compensation. In the acute phase, there is no compensation. When there is acutely increased blood coming into the left ventricle, in case of acute MR, the ventricle is not eccentrically hypertrophied to accommodate the blood, leading on to increased left atrial pressure. In case of chronic mitral regurgitation, the increased blood that is coming into the left ventricle is compensated by eccentric hypertrophy. So we don't see usually increased left atrial pressure. Then we saw chronic MR, the etiopathophysiciology, the primary and secondary MR, the pathology in the mitral regurgitation leading on to eccentric hypertrophy and leading on to left ventricular failure eventually. The clinical manifestations, mild to moderate or asymptomatic or have palpitations. The severe MR presenting with the features of left ventricular failure. The examination findings. On general physical examination, we see pseudo collapsing pulse. BP will be narrow pulse pressure we see, and prominent V wave. The CVS findings: soft S1, wide splitting S2, and S3 is seen even without failure. Note this point: S3 is noted even without failure. I am mentioning this because S3 is also seen in left heart failure. Even if the patient doesn't have left heart failure, the patients with MR, that is mitral regurgitation, S3 will be heard. The murmur, we see pansystolic murmur radiating to axilla and back. The treatment we saw in symptomatic patients and asymptomatic patients with ejection fraction less than 60 mmHg, left ventricular end systolic pressure more than 40 mmHg, will do mitral valve repair, or we can do mitral valve replacement. This is the story of mitral regurgitation. What is aortic regurgitation? The aortic valve should close during diastole, and it should prevent the blood coming from aorta into the ventricle during diastole. If it fails to do that, it leads on to aortic regurgitation. What is the etiopathophysiciology of aortic regurgitation? We have congenital and acquired causes. The congenital causes of aortic regurgitation is quadricuspid valve. Normally, we have three cusps in aortic valve. If the patient has quadricuspid valve, he is more prone to develop aortic regurgitation. If the patient has bicuspid valve, he is more prone to develop aortic stenosis. What are the acquired causes of aortic regurgitation? The acquired causes can be divided into two based on mechanism causing aortic regurgitation. The leaflet may be destroyed in some conditions, or the root of aorta may be dilated, leading on to aortic regurgitation. What are the acquired causes of aortic regurgitation? We have the rheumatic heart failure leading on to aortic regurgitation. The Takayasu arthritis leading on to aortic regurgitation due to the inflammatory damage. The ankylosing spondylitis destroying the leaflet leading on to aortic regurgitation. Or we may have the dilatation of root due to collagen vascular disease. In collagen vascular disease, there is lax connective tissue in the body leading on to dilatation of root, seen in case of Marfan syndrome and Ehlers-Danlos syndrome, leading on to aortic regurgitation. In certain rheumatological conditions like Takayasu arthritis, Behçet's arthritis, and IgG4 related disease and Cogan's disease, we can see aortic root dilatation leading on to aortic regurgitation. These are all the etiology, congenital and acquired causes. Now, what is the pathophysiology going on in aortic regurgitation? During diastole, the blood should not come back to left ventricle. But in case of aortic regurgitation, where the aortic valve are faulty, they are damaged, the blood comes back to left ventricle. This will lead on to eccentric left ventricular hypertrophy, as in case of MR, where we also see eccentric left ventricular hypertrophy and dilation. The eccentric left ventricular hypertrophy and dilation may eventually have the back pressure over mitral valve, causing secondary MR, mitral regurgitation. Then eventually the eccentric left ventricular hypertrophy will lead on to left ventricular failure. We also see that in mitral regurgitation. Following left ventricular failure, we know that due to back pressure in severe AR, due to increased left ventricular end diastolic pressure, we may see pulmonary edema. This is the story of aortic regurgitation, where first we see diastolic dysfunction leading on to regurgitation of blood, which leads on to eccentric left ventricular hypertrophy and dilation, may eventually lead on to left ventricular. What are the clinical manifestations seen in aortic regurgitation? The mild to moderate cases of aortic regurgitation are asymptomatic usually. The severe cases of aortic regurgitation will have features of left ventricular failure. Characteristically, in case of aortic regurgitation, we see nocturnal anginal pain. Why nocturnal anginal pain? During sleep, we know the parasympathetic system is more active than sympathetic nervous system. Due to that, there will be bradycardia. Due to bradycardia, there will be reduced blood reaching on to coronary vessels, leading on for reduced coronary blood flow, manifesting as nocturnal anginal pain. These are all the features in asymptomatic and symptomatic aortic regurgitation. due to hyperdynamic circulation that we see in aortic regurgitation. What is this hyperdynamic circulation? See, I mentioned this previously also. Due to more and more coming into the left ventricle following diastole, the left ventricle will be dilated due to Frank Starling's law. It leads to increased contraction, force of contraction during early systole, leading to rapid upstroke of blood. Following that, during diastole, there will be regurgitation of blood into the left ventricle leading to rapid downstroke. This leads on to the famous collapsing pulse. And also due to this reason, we will have wild pulse pressure. Due to eccentric hypertrophy and increased stroke volume, as I mentioned previously, there can be bounding pulse. We have bounding pulse and collapsing pulse in case of aortic regurgitation. And also we can have the features of pulmonary edema at the end stage due to secondary to left ventricular failure. So the clinical manifestation I summarize. Sorry, before that I missed the clinical manifestations due to hyperdynamic circulation. Due to hyperdynamic circulation, the increased ejection of blood from the left ventricle during systole can be nodding of head by the patient. This is called as Demoset sign. There can be pulsations in the uvea called as Muller's sign. The pulse abnormality, that is collapsing pulse and the bounding pulse, we can palpate in the radial artery. Dancing carotid pulse is called as Corrigan's sign. And also murmur that we observe in case of femoral artery is called as Duroseus murmur. These are all some signs that we see in case of aortic regurgitation. We have so many signs. In that I have taken Demoset's sign, Muller's sign, and Corrigan's sign for discussion. I think 2 to 3 signs should be okay for us. Now, what are the murmurs and auscultatory findings that we see in case of aortic regurgitation? Due to aortic regurgitation, we will see soft S1, and also we see early diastolic murmur. We all know that in aortic regurgitation, there is blood coming from the aorta into the left ventricle during diastole. The amount of blood coming at the early part of diastole is more compared to end part of diastole, leading on to decrescendo early diastolic murmur. So we see decrescendo early diastolic murmur in case of aortic regurgitation. These are all the clinical manifestations that we see in aortic regurgitation. Those are the patient can be asymptomatic in mild to moderate disease, nocturnal anginal pain, the pulmonary edema and dyspnea in case of left heart failure, the collapsing pulse, the wide pulse and bounding pulse that we see in case of aortic regurgitation. Due to hyperdynamic circulation, we see Muller's sign, Demoset's sign, Corrigan's sign, Durosier's sign. And also on auscultation, we see soft S1 and early diastolic murmur, decrescendo early diastolic murmur in aortic regurgitation. Now, what are the investigation findings in case of aortic regurgitation? On X-ray, we see ventricular dilatation. I told that during pathophysiology, there will be eccentric hypertrophy of left ventricle. So you will see ventricular dilatation on X-ray. On ECG, due to eccentric dilatation and other causes, we can see tall R wave, which is more than 25 mm, and upright T wave. On 2D echo, we can beautifully see the defective valve and the aortic regurgitation. These are all the investigation findings in aortic regurgitation. Now, what are all the complications? We have mechanical complications, that is left ventricular failure. Due to eccentric hypertrophy, we have left ventricular failure. The heart is eccentrically hypertrophied, and due to the impaired left ventricular musculature, we have ectopic beads and it may lead on to ventricular tachycardia and ventricular fibrillation. And also, following left ventricular failure, we may have thromboembolism. Due to the defective valve, the defective valve are more prone to develop the infection, thrombi. We may have infective endocarditis secondary to aortic regurgitation, valve defect. Do we treat this patient? We have supportive treatment and surgical treatment. In supportive treatment, we can give digoxin, diuretics, antiplatelet drugs, and antibiotics. Antibiotics to prevent infections, antiplatelets to to prevent the complications of thromboembolism, diuretics and digoxin in case of left ventricular failure. That is supportive treatment. What is the surgical management? In asymptomatic patients, we have 55 and 50 rule. That is, if the ejection fraction is less than 55% and left ventricular end systolic pressure is more than or equal to 50 mm, we treat in case of asymptomatic patients. Or if the patient is symptomatic, we will go on with treatment. The treatment is aortic valve replacement, followed by adequate drugs. This is all about aortic regurgitation. The etiopathophysio the etiology we saw congenital and acquired causes. The pathophysiology we saw there is diastole. During diastole there is backflow of blood leading on to left ventricular eccentric hypertrophy, then leading on to left ventricular failure, which may eventually cause pulmonary edema. The clinical manifestation we saw, the patient may be asymptomatic. We may have nocturnal anginal pain and the features of pulmonary edema, the dyspnea, orthopnea. And although the clinical manifestation of left ventricular failure we can see in aortic regurgitation. We saw the signs of hyperdynamism. And then we saw on auscultation we can see soft S1, the decrescendo early diastolic murmur. Following that, we saw investigation, that is X-ray, ECG, and echo. Complications: left ventricular failure, ventricular tachycardia, and ventricular fibrillation, thromboembolism, and increased risk of infection. And we saw supportive management, then followed by surgery, that is aortic valve replacement. This is all about aortic regurgitation.